Hi, you guys. It's Dr. Baker Townsend, and I'd like to talk to you about neonatal jaundice. So the first reason, the biggest reason why we have high neonatal jaundice levels is because we have ABO and RH incompatibility. Just want to talk about ABO incompatibility very quickly. ABO incompatibility is when the mother is type O. She, over time, naturally develops antibodies against A and B bloods, and it's usually in the foods that she ingests. Some women that are O develop high titers of anti-A and anti-B titers before pregnancy, and so whenever she gets pregnant with a baby who is A, B, or AB, these anti-A or anti-B can cross the placenta and cause fetal hemolytic issues. So, of course, we know whenever there's an antibody that crosses the placenta and that can affect the baby, we know that there can be hemolysis because these antibodies will then attach to the fetal cells, causing hemolysis of erythrocytes in the baby. As a byproduct of that, we know that there is free bilirubin floating around. So the IgG antibodies cross the placental barrier, causes hemolysis of the fetal red blood cells. This will make the Coombs test in the baby positive. So we'll draw a Coombs test on any mom who is a negative blood type or any mom who has an O blood type. We will do a Coombs test on the baby. We'll draw the baby's blood from the cord. We don't stick the baby, but we'll get a blood type on the baby, so we'll know what the baby's blood type is. Of course, if the baby is O and the mom is O, there's no need to worry. And we'll also get the baby's blood type and then the Coombs test. And the Coombs test will tell us how much hemolytic activity there will be in the baby's fetal red blood cell system. So a Coombs test of +1, a positive Coombs test +1, would mean there is going to be some hemolytic activity. +4 would mean severe activity. So the higher the Coombs test is in a quantitative scale, the more we worry about the hemolytic activity in the baby. RH incompatibility, ABO incompatibility is much less severe than RH incompatibility. Sorry. Okay, so now RH incompatibility, and we've talked about this prenatally. Now we're going to talk about it, what happens to the baby. Of course, this is when there's an RH negative mother, and then there's an RH positive fetus, and of course they acquired that through the father's typing, and then the baby has a positive Coombs test. This could be anywhere. That would mean that those antibodies crossed over the placenta and attacked the baby's red blood cell system, causing a positive Coombs test. So this is when mom is Rh negative and dad is heterozygous. That means dad has a positive and a negative. For Rh positive, there will be a 50% chance the baby will be Rh positive. But if dad is homozygous for Rh, meaning the dad is positive, there's a 100% chance that the baby will be Rh positive. So hemolytic disease in the newborn, this is just another review. So Rh negative mom, you can see here, and the Rh negative fetus is here. In the first pregnancy, some of this blood at delivery gets into the mom's system, and the mom then develops antibodies against, here's another one, here's the negative mom's blood type here, and positive baby, and mom's baby's blood will get into the mom's system at delivery, causing her to have an antibody against positive blood. And so you can see this is how this happens. The baby's red blood cells get into the mom's system. The mom develops an antibody because this is not her blood Rh type. So then she's going to have antibodies, and if she gets pregnant again, those antibodies can cross if there is a positive blood type baby again, and those antibodies will destroy the fetal red blood cells of the subsequent pregnancy. So we can prevent all this by giving the mom RhoGAM, but she has to have it every single pregnancy, during pregnancy, and then she gets it after pregnancy if the baby was a positive blood type. So hyperbilirubinemia, you can see here's a healthy baby, and you guys, healthy babies look pink or they look grayish. They don't look like they have great color. If they look like they have great color, that's usually jaundice. So there's a couple types of jaundice. The first one is pathologic. You guys, any bilirubin over 5 milligrams per deciliter per day on the first day is considered ominous. So you guys, pathologic, what you really need to know is it appears in the first 24 hours. That's how we know it's really high. And the total bili is 5 milligrams per deciliter on that first 24-hour period. So what causes neonatal jaundice? We've talked about this: Rh and ABO incompatibility, maternal infection, diabetes, oxytocin administration during labor, because this can injure the baby. Maternal ingestion of some meds, like sulfameds in the third trimester, can cause fetal anemia. Prematurity, polycythemia, too many red blood cells circulating. Usually polycythemia, babies develop too many red blood cells when there is intrauterine placental insufficiency, and that's just because they're trying to pick up every little tiny bit of oxygen they can. So as a compensatory mechanism, they just make extra red blood cells. Well, after delivery, they get rid of those extra red blood cells and they lyse. Pyloric stenosis, it can cause damage. Sequestered blood, again, cephalohematoma, any bruising on the baby, anything that caused damage and caused the red blood cells to lyse. And then maternal blood swallowed by the neonate. So it's physiologic. The liver takes approximately 2 weeks to become mature. It's just very slow to start working. So you guys, after birth, it's very slow at processing the byproduct of the lysed red blood cells that are not needed. So just remember, you know, the baby has all that extra blood in the cord and in the placenta, and so the baby's going to have extra red blood cells. The good thing about that the baby has extra red blood cells and they lyse, is that the baby gets extra iron. But the not so great thing is the baby will have higher levels of bilirubin. So it takes a couple of weeks for the liver to really to start working as it normally would. This is due to the low ligandin levels and the high number of destroyed erythrocytes. So after about 2 weeks, this works itself out, but the first 2 weeks we can have a lot of trouble processing this bilirubin. Physiologic hyperbilirubinemia affects about half the newborns. It's just because their liver's slow. And physiologic jaundice comes after 24 hours. Remember, so important to remember. Pathologic or disease-producing is before 24 hours, and then physiologic, just normal jaundice, is after 24. This is just physiologic jaundice. You can just see this baby's yellow. So breastfeeding, you guys remember they don't get a ton of volume. Their milk comes on day 3 to day 5, and so you can see that this is just because they're not getting enough volume to excrete the high levels of bilirubin. So you guys remember our little saying, the more you pee, the more you poop, the more bilirubin will come out the chute. So breastfeeding, you know, you just have to, it takes time for them to get the volume in. So you'll have some babies that just don't have enough volume, and it's taking a little while to get it in. Rises on the 4th day, peaks at day 10 to 15, and usually returns. So usually it's okay. It just takes a little while to get that volume in. So what do we do as nursing care? Of course, we assess the newborn. If we see that the newborn looks yellow, of course, we're going to do a screening test with the bilimeter, and place it on the baby's head. It's non-invasive, and we'll find out a screening value. If the screening value is elevated, you guys, we have standing orders to do a blood serum, and so we have to notify the provider of these serum events. Offer early feedings. Again, the more you pee, the more you poop, the more bilirubin comes out the chute. So you guys, feeding. This is why your urine's yellow and your feces are brown. It's the byproducts of that bilirubin breakdown, and so you guys, you really need to get them to feed. Give the vitamin K, and you guys, the vitamin K is so important to prevent a brain bleed, and it also decreases prothrombin time. So if it gets to the point where they need phototherapy, you're definitely going to use very cautious nursing care with that. You have to protect their eyes and their genitals, otherwise they're naked. So they're not completely naked. They have their eyes covered and their genitals covered because the skin is just so thin on their eyes and on their genitals, which can cause damage to those organs and structures. You turn them every 2 hours. You want to maintain hydration and nutrition. If they get too hot, they start they'll have sensorial loss, and they'll just start breathing and panting, and they'll just get super dehydrated just simply from being too hot. So you have to be really careful with these lights and monitor the temperature of the baby, the respirations, urine-specific gravity. You don't want them to become concentrated, eyes and O's, and just make sure they feed. These are the little eye goggles. These are eye goggles, and they can be held on by these little straps. But the baby always has to wear the eye goggles during the jaundice sessions under the phototherapy. Observe for the side effects of phototherapy: bronze skin, cholestatic jaundice. You guys, that's sometimes, congenitally, the bile duct may be narrow, and so there's a hard time getting the bilirubin out. Skin rash, decreased activity. You guys, they have loose green stools. So bilirubin absorbs the light and changes the bilirubin into partially soluble products, and it's excreted in the stool. So let me just draw you a little picture right here. So we'll say this is the liver, okay, and this is the blood flow going to the liver for processing, and then here's the blood flow going out, or this is coming off of the liver. All right, so you have bilirubin in here, and the bilirubin that is flowing to the liver is unconjugated. That means it is not water soluble, so it's uncool to be unconjugated. So this bilirubin goes to the liver for conjugation, and remember, the liver is very slow, right? So once it gets in the liver, it is then processed. It is now water soluble, and it's conjugated, and you can urinate it out. U-R-I-N-E, urine and stool. So you guys, after the liver processes it, you will, it's now water soluble, and it goes out of the, it's processed by the body and is excreted. The conjugated bilirubin is excreted in the urine and in the stool. So the bilirubin that is in the skin, so you guys, of course the babies look yellow. So the bilirubin that's in the skin gets bathed by the light. The bilirubin then changes to luminubin or luminrubin, depending on the text you read, and that is a partially water soluble form of bilirubin. So when they're under phototherapy, it's already partially conjugated. So now, instead of having a totally unconjugated product, you have a partially conjugated product, and so it's much easier for the liver to process this and turn it into conjugated or water soluble bilirubin and to be excreted in the cells. and I mean in the urine or in the stool. What is really fascinating is you can follow trends with this. You can watch the total will continue to go down, but what you'll see as far as a trend is you will see the unconjugated bilirubin go down and the conjugated bilirubin go up. That's how you know that the treatment is successful. You follow the trends in conjugated and unconjugated bilirubin. Okay, and so here's a baby on phototherapy, and this is a premature baby that needs to stay in this isolate just to keep it nice and warm. But you can see their phototherapy, and they're changing and rolling the baby. You can see there's protective eye goggles on and a diaper. What's also interesting is that usually within 24 hours after the skin is bathed, the skin stops turning yellow because the massive blood flow and the how the light will partially conjugate it. This baby will turn pink instead of yellow. And when you take these eye goggles off, underneath these eye goggles, you'll see yellow eyes, or the skin that has not been bathed by this light and change it. You'll see yellow marks around the eyes and yellow marks around the diaper. That usually goes away in about a week. Here is a phototherapy blanket. If the levels are not really high and they want to send mom or dad home on a phototherapy blanket, this is a nice thing. They have at-home phototherapy beds. Here's home phototherapy. And that's it. So the big takeaway points are, you know, pathologic jaundice occurs in the first 24 hours. It's when the bilirubin is elevated greater than 5 milliliters per deciliter. Physiologic jaundice is normal. In order for us to know how normal it is, you have to look up the nomogram, and that's in your book. And the nomogram is on, I'll tell you what page. Well, I can't find it because I have to go into the embedded things, but go to your chapter on bilirubin. But how you know if the bilirubin is elevated, you have to look at the hours, the amount of hours of gestational age that the baby is, and then you look at how high the bilirubin level is, and then that will tell us our risk factor. So make sure you reference the nomogram. Other takeaway points are that if it is elevated and the baby goes on phototherapy, definitely cover the eyes and the genitals during the therapy, turn the baby, check eyes and nose. Remember, the first nursing intervention with any baby that has a positive Coombs or has elevated bilirubin is to feed. You just encourage the mother to feed. The more you pee, the more you poop, the more bilirubin comes out the chute. And then we also follow trends in phototherapy. Make sure that you watch the total fall, but the two components of the total are conjugated and unconjugated. So you guys, you watch the, you want to see the unconjugated fall, you want to see the conjugated elevate, and that will tell us that the therapy is effective and that there will be a quick resolution to the jaundice. Okay guys, please post any questions if you have any. Thank you.